Hi everyone, welcome to CADIO's webinar series. Thanks so much for being here with us. Today we are so excited to have Sophie Green presenting. Sophie Green is a research fellow based at the Leeds Institute of Health Sciences, the University of Leeds, with an academic background in behavioral science and psychology. During her PhD, Sophie developed a multi-component intervention to support medication adherence in women with breast cancer, which included conducting a factorial trial to optimize the content of an information leaflet intervention to support medication beliefs in women with breast cancer. Sophie's overarching research interests focus on the development, optimization, and evaluation of complex interventions in the field of cancer prevention and control. Thanks again, Sophie, for being with us today.
Thank you for the introduction, and yeah, thank you very much for having me and for the invite to talk about some of this work. It's great to be able to talk about it to other people that are also interested in intervention optimization. So today I'm going to talk about a body of work that focused on optimizing the content of an information leaflet to support women with breast cancer. So I'm going to talk about both the preparation and optimization phases of MOST, but with kind of a focus on the decision-making phase, which I've been doing some work in over the past couple of years. So just as a bit of an overview of what I will go through, I'll start off with a little bit of clinical context to this work, just so you kind of understand the setting behind it. I'll then talk about the optimization trial that we conducted looking at this information leaflet. And then I'll talk about two different approaches to decision making that we've used to identify an optimized version of the information leaflet. So I'll talk a little bit about the component screening approach that we used initially, and then the newer method, the decision analysis for intervention value efficiency, that we've applied to the same data set. So to start off with a bit of background, adjuvant endocrine therapy, AET, is a medication prescribed to women with early stage breast cancer for between 5 and 10 years after their active hospital-based treatment has ended. So the purpose of this medication is to reduce breast cancer recurrence and death, so to reduce the risk of those events. However, we do know that up to 75% of women don't take this medication as it's prescribed, and there's a whole range of reasons why women don't take this as prescribed, including things like forgetting to take it, distress they're experiencing during this period, and also some quite unpleasant side effects from the medication, so things like hot flushes, night sweats, joint pain. But one of the most consistently reported barriers to taking this medication is people's beliefs about the medication. And we tend to think about these beliefs in terms of the balance between beliefs about the perceived necessity of the medication compared with someone's concerns about the medication. So there's a framework called the Necessity Concerns Framework that summarises this quite nicely, and there's quite a lot of research out there that suggests that it's this balance between necessity beliefs and concerns that's associated with adherence to adjuvant endocrine therapy. So existing interventions out there targeting medication beliefs, there aren't very many out there specifically targeting medication beliefs. From what is out there, educational methods are the most commonly used approach to address these beliefs. But there is a really mixed evidence base in terms of how effective interventions are in changing medication beliefs. And I think it's important to highlight that there was a very recent review that came out. This came out actually after I'd conducted all of this work, but it's very, very relevant to the work. So it looks at changing medication beliefs across a whole range of different conditions, and it highlights that it definitely is possible to change medication beliefs. And there's certain behaviour change techniques that may be more helpful than others, but it's not exactly clear what specific strategies might work to change medication beliefs for individual conditions or individual medications. And it also highlights that we don't really know kind of how exactly these strategies work, or any kind of interactions between them either. So medication beliefs in themselves are quite complex. It's not a simple construct, and so using a multi-component intervention to actually target them could be a useful approach. So in saying that, an educational intervention is a multi-component intervention in itself, or you can think of it like one. So for example, in a leaflet, there's lots of different types of information included, all displayed in kind of varying formats in different ways. So for example, you can have diagrams in a leaflet, different messaging about side effects, different types of information. And it hasn't really been looked into before, kind of exactly how effective these strategies are. So that's why we don't really know a huge amount about how effective strategies to change medication beliefs are. Another limitation of existing research is that often any multi-component interventions are evaluated using parallel groups randomized control trials. As I'm sure many of you are aware, these are really great at telling us if that intervention as a whole is more effective than a comparator, such as usual care. But it doesn't tell us kind of which individual components might be affecting the outcome, if there's any interactions between those intervention components. So you might have kind of components in there that are redundant or that are even negatively impacting your outcome. So in this case, medication beliefs. So that's why we decided to use the multi-phase optimization strategy to try and optimize an intervention to support medication beliefs. So I won't go into lots of detail about this, as I'm sure most people are quite familiar with this framework. But as I said, I'm going to talk through the preparation and optimization phases of this work in a bit more detail, and then move on to decision making. So our overall aim to start here was to prepare and optimize an information leaflet intervention to increase necessity beliefs and reduce concerns about adjuvant endocrine therapy. So to start in the preparation phase, here we thought about developing a conceptual model and developing candidate intervention components to test in the optimization trial. So this is our conceptual model that we developed, and this is based on theory and evidence. But what I will say is, because this hasn't really been looked at, people don't tend to break down information leaflets into such kind of granular and small components. It was quite difficult to put it together and to kind of hypothesize what each target would be and how we can best target. But we did as good a job as I think we could, based on evidence out there and relevant theories to medication beliefs as well. So just to talk through this in a little bit more detail, I'll start from the right and go across to the left. So our primary outcome here was beliefs about medication, and this is called a BMQ AET differential. This is just a score from a questionnaire that you can calculate that is a balance between someone's beliefs about the necessity of the medication and their concerns. So you subtract one subscale from the other to give one overall outcome there. So to make this differential more positive, we wanted to increase necessity beliefs and reduce concerns. And to do this, we hypothesized 5 mediators that could some of them would aim to increase necessity beliefs, and some of them would aim to reduce concerns. So we had treatment control, which is about how likely people think the medication will be in controlling cancer and reducing risk of recurrence. Coherence, which is all about understanding how the medication works and how it has these benefits. Misattribution is referring to misattributing symptoms to a medication when someone might have experienced these anyway. So a lot of the symptoms from adjuvant endocrine therapy mimic menopausal symptoms. So women might have experienced these anyway, but obviously when you take a medication, you might attribute these to that medication. Negative expectations is about the expectations someone might have about a medication when they're starting it, and how this can actually influence their experience of that medication. And then our patient input component was there initially to try and increase the engagement with the information leaflet overall. So we thought by including kind of quotes and pictures from breast cancer survivors, this would encourage people to kind of read the rest of the leaflet and feel it was coming from a more credible source. So then we developed 5 candidate intervention components, one to target each of these mediators. I'm going to talk through those in a little bit more detail in a moment. But just to finish off the conceptual model, we also hypothesized some interactions, which hopefully you can see in the dashed lines here. And these were because we thought the components were quite granular, and we thought interacting would be quite an important part of this. But again, to say that there's not a huge amount of research out there about how different strategies interact together. So again, this was based on kind of theoretical constructs and what we thought might interact. So that was our conceptual model overall. I'll talk through briefly a little bit about the candidate intervention components, just to provide a bit of context before I talk about the optimization trial. So our first component was our diagrams component. So this explains exactly how the medication works using 3 different medical diagrams. and that's supplemented by text explaining those diagrams as well. Our benefits component displays the benefits of the medication and tries to really enhance these by talking about how the medication can reduce risk of recurrence and risk of death. Our side effects component included quite a detailed table about the side effects of the medication. So there's different types of AUT, and it goes through the prevalence in quite a lot of detail about the types of medication. And it tries to positively frame these. So for example, saying things like 99% of women won't experience certain side effects. So to explain, kind of a large proportion of women actually won't experience these side effects as well. Our concerns component had 4 common concerns that women often report when taking this medication, and it provided an answer to try and provide some reassurance surrounding some of these concerns. And then finally, our patient input component provided 4 quotes and pictures from breast cancer survivors about their motivations to take the medication, and these were interspersed throughout the leaflet. So onto our optimization phase. So the aim here was to develop a leaflet that contained only components that were contributing positively to our outcome. So the initial outcome was beliefs about medication. And so in this sense, we were looking to improve the efficiency of the leaflet. So we didn't want to be including information that was not having any impact, and we didn't really want to include information that wasn't positively impacting medication beliefs. So we ran an online study with just over 1,600 women recruited. They were recruited via a market research company, and the only criteria was that they had to be female, over 18 and able to read English. So what we asked them to do was to, first of all, read a scenario about the context in which they might be prescribed this medication, asking them to imagine that they were in that situation. And that's because it was a sample of healthy women, so we wanted to contextualize it a little bit first. We then asked them to complete a questionnaire about their beliefs about the medication. They were then randomized to view one of 32 versions of the information leaflet, and we then asked them to complete another questionnaire about their beliefs about the medication, but also about their knowledge about the medication and their satisfaction with the information that they'd received. So we used a 2 to the power of 5 full factorial design. So we had our 5 candidate intervention components operationalized as factors, and each of these had 2 levels. So 3 of our components could be on or off. So for example, you either receive the quotes from breast cancer survivors, or they just wouldn't be included in the version of the information leaflet a participant received. 2 of our components could be enhanced or basic, so that was the benefits and the side effects component. So for example, with the side effects component, you would either receive that enhanced version of the side effects table, which is the one I showed you, or you would receive a much more basic level of side effect information, not going into as much detail about the prevalence of side effects. And we did this because we felt any leaflet that we developed would need to have at least some information about benefits and side effects of the medication. So we didn't want it to be a kind of on versus off scenario. So this was our experimental conditions. So every possible combination of all the levels of our 5 factors was included in these 32 conditions. So participants were randomized to one of the 32 conditions, which would determine the version of the information leaflet they received. So for example, someone randomized to condition 1 would receive a version of the information leaflet where all the factors were set to their higher level. So in our analysis, our primary outcome was medication beliefs. We set our statistical significance at 10%. So anything with a value of less than 0.1, a p-value less than 0.1 was deemed an important main or interaction effect. And that's because we tried to balance type 1 and type 2 error rates that we felt would be equally detrimental in this screening experiment. We use a multiple linear regression with effect coding, and we did also repeat the analysis as sensitivity analysis, where any women that had reported a diagnosis of breast cancer was removed, and we also removed speed responders in the sensitivity analysis, just to check that there weren't lots of people kind of just rushing through the online experiment and putting in invalid responses. So on to our results of this study. So we had just over 1,600 women participate, and the vast majority of these were white British. Around a third had degree level education, and around 5% reported a diagnosis of breast cancer. And of these 5%, around 3/4 had experienced taking AT, which is what we might expect. So we found one main effect for the patient input component, and that was the only component having an effect by itself on beliefs about medication. We then had two-way interactions, so one between the diagrams and benefits, and one between diagrams and side effects. We then had a three-way interaction between the diagrams, concerns, and patient input, and a four-way interaction between the diagrams, benefits, side effects, and concerns. So two of these interactions were synergistic. So by that I mean the effect of one component sort of enhanced the effect of another, and two were antagonistic, which you can see by their negative coefficients. So the effect of one component reduced the effect of another. And I will talk about these interactions in a little bit more detail in a moment when I talk through the decision-making phase. So once we conducted our optimization trial, we moved on to decision-making. This is using the optimization trial data to decide actually what makes up the optimized intervention. So initially we started off by using the component screening approach, which at the time of conducting this was the recommended approach to deciding the optimized intervention. We saw this as a stepped approach. So we started by screening in any components which had a main effect. We then reconsidered decisions based on important interactions, then set components to their corresponding levels, and that led us to create our optimized intervention leaflet. So to talk through these steps in a little bit more detail, so our first step was to screen in any components with a main effect. So this for us was just that patient input component, and so we put that on our screened in list. We then had a look at the interaction effects and reconsidered decisions based on this. So the first interaction that we had a look at was this three-way interaction between the diagrams, the concerns, and the patient input components. And we looked at this one first because it was the only interaction which contained a component that had shown a main effect, so that it was the only one to contain patient input component. So what we found here is that when patient input was set to its higher level, so on, which is over on the right-hand side here, this was where our best outcome was when the patient input component was set to on and concerns was also set to on this dashed line here. So we decided to then screen in our diagrams and concerns component because they were all set to on in the best outcome. We then looked at our two-way interaction between the diagrams and the benefits components. So here the best outcome was either when the benefits and the diagrams components were both set to their high levels or when they were both set to their lower levels. So given that we'd already screened in the diagrams component, we felt it was more beneficial at this point to also screen in the benefits component as well. So we screened in the benefits component at this point. We then looked at our two-way antagonistic interaction between the diagrams and the side effects component. So this was an antagonistic interaction, as I said, meaning the effect of one component reduced the effect of another. So when both components were set to their higher level, which is over here, the effect was smaller than might be expected with no interaction. So when side effects was set to the basic level, the outcome was higher. So at that point, we decided to screen out our side effects component. Finally, we had a look at our four-way interaction between the diagrams, benefits, side effects, and concerns. Again, this was antagonistic. So I've put this here, but hopefully this demonstrates that it is quite complex. And so when we got to this and tried to interpret it, it was quite difficult. So there's quite a lot going on in this graph, and I'm not going to try and explain every part of it now. But the way we approached this was by looking at our screened in and screened out list at this point, and to see whether changing those decisions whether changing the level of those factors would have any impact. So we looked at this bottom right graph here. So this is when our benefits, our concerns, and diagrams components are all set to on. If we look at this dashed line, and when the side effects is set to its basic level, the outcome is a bit higher, the expected value is higher, than when it's set to its enhanced level. So at this point, we decided to leave our side effects screened out. So this was our final screened in and screened out list using the component screening approach. So everything on the screened in list was set to either on or its enhanced level, so its higher level, and everything on the screened out list was set to either off or its basic level. So that led us to create the optimized information leaflet. And just to say, I did mention we did a sensitivity analysis where we removed women with breast cancer and speed responders separately. When we reran this, neither of these changed the decision making, and so it was robust to those. We then looked at our predicted outcomes for all 16 conditions, which reflected the combinations of the 4 screened in components. So we used the parsimonious prediction model to compute these, and we found that condition 5 had the greatest expected predicted value, which represented whereby the diagrams, benefits and concerns and patient were all set to their higher level, and obviously the side effects being set to its lower level, which is what the conclusion that we had come to. So after doing this, we felt like we'd balanced effectiveness and efficiency of the leaflet. So we had removed a component, the side effects, the enhanced level of the side effects that seemed to be interacting negatively with the other components. And this helped us to identify specific strategies for changing medication beliefs. So as I said at the start, there's not a huge amount of evidence about specific strategies. So we felt like this was a really helpful approach to identify what strategies might be helpful. However, there's obviously always limitations with approaches, and so there are some important limitations of this component screening approach that we use to decision making. So firstly, interpreting interaction effects, as I've probably just demonstrated, is quite complex, particularly the higher order interaction effects. So trying to unpick that 4-way interaction was quite a difficult process. And so this does leave it down to some level of human judgment. We also relied on arbitrary thresholds to determine what an important effect was. So we used anything with a p-value of less than 0.1 based on significance tests to determine what was important. However, this does mean that the other main and interaction effects not reaching this significance value, even just marginally, were not included in our model. So we didn't include kind of all information that was maybe there. Finally, some of you might have noticed that when we asked the participants to complete questionnaires after viewing the information leaflet, we also asked them to complete a questionnaire about their knowledge about the medication and their satisfaction with information about the medication. The component screening approach is quite difficult to apply to more than one outcome, and so therefore we only considered medication beliefs as that was our primary outcome and our primary targets for the information leaflet. But knowledge and satisfaction with information have also been associated with medication adherence, which is our kind of end goal here. And so they could also be important to consider when optimizing an intervention as well. So that's where the newly recommended approach comes into this. So decision analysis for intervention value efficiency, or DAVE. So it's very much led by Gillian. I know she did a talk on this very recently. So I won't go into huge detail about the methods, but I'd encourage you to have a look at these papers if you would like more detail. But at this point, I was lucky enough to win something called a Health and Behaviour Collaborative Award, which allowed me to work with Gillian and Linda to apply this new approach to my data set. So I'm going to talk through what that looked like now. So very brief overview of DAVE. It makes use of a Bayesian paradigm compared to the component screening approach, which is perhaps more embedded in more frequentist principles. So you use a Bayesian ANOVA. It summarizes evidence about main and interaction effects using posterior distributions. The posterior distributions are obtained for expected outcomes associated with all versions of the information leaflet, so all of those 32 versions that I showed earlier. There's no need for preliminary screening, so that screening approach that I've just shown you isn't needed, so you can calculate an expected outcome without going through the screening process. And depending on the optimization objective, the optimized intervention could be one that maximizes your expected value, or you can try and balance the expected value strategically with other criteria such as cost or time. And what's really great about the approach is that you can consider perhaps more complex criteria in the decision making. So for example, considering multiple outcomes. So we applied Dave on the same 2 to the 5 factorial data that I've spoken about. So it consisted of 3 outcomes, so beliefs about medication, knowledge and satisfaction. We used non-informative priors, and we did control for baseline medication beliefs, which we also did when we used the CSA approach. So we used a swing weighting exercise to scale and assign weights to the 3 outcome variables that I've spoken about. So medication beliefs we considered the most important, and so we assigned that 100 points. We then decided that objective knowledge was the next most important outcome, so about half as important as medication beliefs. So we assigned that 50 points. And then that satisfaction with information was half as important as objective knowledge, and gave this 25 points. So you can then calculate the value function, which I've just put at the bottom here, by just dividing those points by the total number of points. And we then put all the outcomes on the same 0 to 1 scale, so they were comparable. So 0 was the worst and 1 was the best. We applied the value function that I've just shown you to estimate expected values for each intervention, so for each of the 32 versions of the information leaflet. And our goal here was to really improve the efficiency of the leaflet by removing any redundant or potentially harmful components. So we didn't consider criteria such as cost, because cost of an information leaflet isn't all that interesting. It doesn't vary too much between the versions. So we were really looking at improving the efficiency of the leaflet. And we were looking to identify the leaflet version with the largest expected value as the optimized leaflet. And I should also say at this point that this analysis was very much led by Gillian. So yeah, if you've got kind of detailed questions about that, as I say, have a look at the papers, and she might be able to answer them as well. But to talk through the results of this work, so these are the credible intervals for the estimated main and interaction effects on all 3 outcomes. So I appreciate these are quite small here, so you won't be able to see them in a lot of detail. But up here it shows that our patient input component had a main effect again on the beliefs about medication. But also what it's showing is that there's lots of interaction effects. So that's where the credible interval isn't crossing the 0 line. So it's kind of suggesting that there's a lot of complex synergistic and antagonistic effects on all 3 outcomes. So it's probably important to consider them all. So this table shows the expected values for all 32 versions of the leaflet when we considered all 3 of those outcomes, so beliefs, knowledge and satisfaction, at the weights that I've described. So for these, they're ordered in magnitude, so the highest expected value is at the top, which I've highlighted here. So the leaflet where side effects and the patient components were set to their higher levels were the ones that was the version of the leaflet that maximised the expected value here. So based on these results and our initial preferences, when we set side effects and the patient input components to their higher levels, that was maximising our expected value. So we then also wanted to explore the robustness of our decision to see whether the optimised intervention would be different if we used different weights for the outcome variables. So we started this off, first of all, by varying the outcome weights that we had assigned, but by upholding our initial preferences. So what I mean by that is upholding the idea that beliefs is more important than knowledge, which is more important than satisfaction with information. So these were our initial weightings that we started off with, which I spoke through earlier. We then reduced the importance, first of all, of the satisfaction variable until the importance of this was very small. So we went to 15 points, then 5. And then did the same with objective knowledge, so going from 50 right down to 5 until they were very small, whilst keeping everything else constant. So we again looked at which version of the leaflet maximised the expected value, and here it was the same across all weightings. So the version where side effects and patient were set to their higher levels maximised the expected value. In step 2 of exploring robustness, we went the other way. So we started by increasing the importance of the knowledge outcome first, holding everything else constant. So you can see here incremental increases until the knowledge outcome reached 100. And then increased satisfaction until all 3 outcomes reached 100. We again looked at which version maximised the expected value, and again it stayed very robust. So the version where side effects in patients set to their higher levels maximised that expected value. So when we kept those initial preferences the same, our choice didn't change, it was quite robust. So I appreciate this could lead you to think it doesn't really matter what points are assigned to those variables. So to contextualise this a little bit more, we also considered some preferences for the outcomes that differed from our initial preferences. So differing from that concept that the order was beliefs, knowledge, and then satisfaction. So here you can see some of the preferences that we looked at. So for example, we reversed secondary outcomes. We looked at using 1 outcome only and using 2 outcomes only. So here we saw a lot more variation in the version of the leaflet that maximised the expected value. So for example, you can see here the version where diagrams, benefits and patient were set to their higher levels was coming through as maximising the expected value in a few cases. So for example, when we reversed the secondary outcomes and we had beliefs only, satisfaction only, or beliefs and satisfaction. So there's a bit more variation in this here. So I just wanted to kind of finish off by talking about a few points of discussion and what we can take from this work and from using the 2 different approaches. So first of all, using Dave and the CSA. So compared to the results earlier, we obviously had 2 different kind of optimized leaflets, if to call it that. So using Dave, we had the side effects and the patient set to their high levels, and using CSA, we had 4 components, so diagrams, benefits, concerns, and patient set to their high levels. Here, this is totally expected because using Dave, we had 3 outcomes. We were looking at performance across those 3 outcomes, whereas using the CSA, we were looking at beliefs only. So this is probably just demonstrating that there's varying patterns of component performance on those 3 outcomes, which might lead to different versions of the leaflet. However, you might have noticed that when doing those robustness checks, we did have one scenario using Dave in which medication beliefs was the only outcome that we considered. So on the left was the that version, and then on the right is just the CSA again. So the difference here was that the concerns component was screened in when using the CSA compared with Dave, where it was obviously screened out. Again, this is not hugely unexpected. So in Gillian's simulated testing of Dave, it frequently but not always arrived at the same optimized intervention as the CSA. So it's not hugely surprising. And it's probably possible that some of the judgment calls that we made when interpreting those higher order interactions when using the CSA potentially led to this difference here. Another important message to be taken from this, I think, is about the robustness checks that we did and the importance of making initial decisions about the weighting of outcomes and the kind of ordering of those outcomes. So on the left is just demonstrating that when we change the weighting but kept our kind of prior beliefs the same, so beliefs more important than knowledge, which is more important than satisfaction, our choice remained exactly the same. But when we did deviate from those initial preferences, our selected optimized leaflet changed a lot more depending on the different preferences that we looked at. So potentially an important thing to think about in the preparation phase of most about a kind of weighting of different outcomes and what you're actually expecting before you actually go and do the analysis. You may have also noticed that we did have 2 kind of top contenders for the leaflet when they were analysed using Dave. So one version with 2 components set to their higher levels and one with 3. So the expected values was quite similar across these. It's not unique to Dave, so this was also the case when using CSA, but some explanations for this. So for example, our components were quite granular, and by that I mean kind of quite small. We were testing higher versus lower levels of components in some of them. So we might expect quite small differences between the expected values. What it does kind of suggest to us is that patient component was the strongest, and it's perhaps considering the synergies with other components. So there might be some sort of antagonism between the side effects and either the diagrams or benefits components, meaning that for some reason they can't kind of all be included in one. In other scenarios, we might have other data such as cost that might help to distinguish between two interventions with expected values that are quite similar. So for example, you might favour the lower expected value if it gives you some cost savings. But as I said, in this case, we weren't really considering other constraints such as cost. But again, it might be something important worth thinking about kind of earlier on, perhaps in the preparation phase, if you do end up with interventions with very similar expected values, how would you actually decide what to proceed with? So then just some future kind of directions that have come out of this work. So firstly, when we chose the weighting of the variables, two investigators just chose them ourselves, so it was myself and one of the co-authors. So in future, a larger range of interested parties could be involved in this. So people like patients, healthcare providers, they might have different priorities in terms of outcomes. So it might be important to consider those as well. To further distinguish between our top two contenders, we could have included kind of other criteria. So things like for an information leaflet, maybe the attention of the information leaflet could have been useful to consider, but would have involved kind of collecting more data that we didn't do. And then finally, quantifying uncertainty might also help to distinguish between those top two contenders. So the choices we make do have a certain level of uncertainty surrounding them. And so quantifying that might help to distinguish between those two versions. And finally, to finish off, hopefully this is helpful and not confusing, but just to place this work in a little bit more context in terms of a much broader research programme that it's part of. So the information leaflet that I've been talking about today forms part of a much bigger intervention to support medication adherence overall. So this is kind of what I was looking at here. So it's almost optimization within optimization. So the information leaflet will now be included in a much larger optimization trial consisting of other intervention components, all overall aiming to support medication adherence in women with breast cancer. So thank you very much for listening, and just to acknowledge all the other people who have had massive impact on this work. And then a kind of very short plug that I am heading over to Philadelphia in a few weeks and presenting some of this work in the first poster session. If you'd like to come and say hello or have a chat, I'd be very open to that.
Wonderful. Thank you so much, Sophie. That was so interesting and so clearly explained. I want to open up the floor now for questions. If you have a question for Sophie, please feel free to put it in the chat, or you can raise your hand. To kick us off, Mackenzie raised the question of whether you looked at health literacy in your sample and whether you have any thoughts about health literacy as a potential moderator, and whether you looked at that at all.
Yeah, so we didn't collect any data on health literacy, but I think if I did it again, perhaps that would, I think it absolutely could impact people's kind of use of the leaflet. What we did do, which is not the same thing, but in an attempt to kind of acknowledge this, we looked at the readability of all the versions of the information leaflet. And I appreciate that's not a hugely great measure of kind of literacy or understanding, but we tried to kind of get that readability level to a kind of average reading age to try and acknowledge that. But I think collecting data on health literacy would be interesting and probably important.
Yeah, and I always have a million ideas of ways I would improve an experiment kind of after it's done. So I appreciate that. I think too, just kind of thinking about, I mean, well, one, you did collect education, which is highly correlated with health literacy. So you, kind of could look at that as a proxy-ish. But two, just thinking about like moderators in this decision-making approach is something I was wondering about more broadly, whether it be health literacy or something else, the idea that the optimized intervention may be different based on participants' baseline characteristics. And if you or others on the call have thoughts about that, I'd be really interested.
Yeah, I'll just say briefly that we have thought about that some. I've seen it come up in a few other grant proposals or early applications of this. One of the challenges is when that is a goal, there tends to be a need for some parsimony in the process, of having a very clear moderator measured in a very specific way with a very specific hypothesis behind it, which is frequently poses some challenges. But I have seen people think this through some. One strategy is to try to have a sample that is large enough and diverse enough that you might be able to think about looking at a decision specific to a certain subgroup of the sample. Otherwise, you could build in the moderator into your model for the decision-making process itself. There are different ways you could do it, but you absolutely could carry out a decision-making process that tries to acknowledge that. It, of course, just raises some more dilemmas about whether that means there should be two versions of the optimized intervention. But I think in this case, it might also be sort of interesting when there are two top contenders, like Sophie described, that are very close in expected value. Doing an additional secondary analysis with the moderator might be an interesting way to learn a little bit more about the relative performance of those two.
Yeah, absolutely. Thanks, Jillian, for speaking to that. And Sophie, I'll also be in Philadelphia, so can't wait to see you there. And
great. So there's also a question in the CSA approach, wouldn't using a factorial MANOVA be an analogous application for multiple outcomes? And yes, we have, I say we primarily to refer to Linda, in the early days of talking about the decision-making approach with multiple outcomes, we did talk a little bit about that. The challenge really comes in when you have multiple outcomes that might have key differences. You might have a binary outcome, you might have a continuous outcome, or you might want to combine your outcomes with the ability to quantify uncertainty about the estimate for the combined outcome. So there would be different ways to go about this, but the Bayesian paradigm has particular advantages with the combination of more complex outcomes and then quantifying uncertainty around those estimates for combined outcomes. Linda, is there anything else you would add to that?
Well, just that factorial MANOVA, if I'm remembering correctly, at least some versions of it, it's kind of like a principal components analysis on the y side of the equation, and that means that the weights would be empirically derived, and in Dave the decision maker specifies the weights, which I think is an important distinction.
Thanks. Another question from the chat, Sophie. Maggie Price says, thanks so much for this great talk. Regarding future directions, can you expand more on the first two directions? One, inclusion of other interested parties, and two, alternative optimization criteria to help distinguish those top contenders. She says, you mentioned costs, but to play devil's advocate, what if the costs were the same between the two top contenders? How might you decide which one to move forward with?
Yeah, sure. So the first one, inclusion of other interested parties. So that was with reference to the weighting of the outcomes that we chose. So we kind of assigned 100 points to medication beliefs, 50 to knowledge, 25 to satisfaction. So that just involved me and one of my co-authors kind of deciding that. We didn't, I guess, ask anyone else. We just decided that that was the case, and it was based on kind of some evidence and theory. There was some thought into it, but in terms of interested parties, I think first of all, women with breast cancer, it would have been useful to talk to them about what outcomes would they prioritize, because maybe it's not just about changing medication beliefs. I imagine for them, kind of the satisfaction with information, maybe they would have weighted that higher. Also healthcare providers, like what they would want to be kind of optimized. And I imagine we would all have slightly different preferences. So that I think that that would be a task in itself in kind of deciding on the weighting that kind of multiple groups are happy with. But I think it's important in outcome variables, and I think it could be applied here in the sort of decision-making aspect as well. Then alternative optimization criteria to distinguish the top contenders. Yeah, so obviously I mentioned cost. We didn't consider cost here because it would have been the same between the top two, because different costs of the information leaflet wasn't very varied. But I think, yeah, I mean, if it was the same, that wouldn't help you to distinguish. In this case, there might have been more useful variables. So I mentioned briefly kind of attention. So you could look at this in a lot more detail, like eye tracking devices, to see what attention they're paying to the information leaflet, or considering kind of the perhaps like perceived burden of different components of the leaflet. Maybe some of them are much harder to understand than others, and participants don't like them. So maybe thinking kind of for interventions like this, thinking a bit broader than just cost, of what could help distinguish between those kind of top contenders. That's what I was getting at there. But if that data is the same for those top two contenders, I don't necessarily have an answer of what you would do in that situation. Yeah.
Can I ask a quick follow-up?
Sure.
Would it make sense to build in, for example, like a qualitative aim or like a community advisory or stakeholder board aim, wherein you, like, I'm thinking kind of in terms of grant writing or project planning, where if you, and it seems like in your research, Dr. Green, this did happen, where you have kind of these two final choices and not a lot to distinguish between the two. Might it make sense to say, you know, if this were to happen, we would convene groups of stakeholders to kind of help us parse this out, including kind of, for example, the groups that you mentioned?
Yeah, I think it's a conversation I've had briefly with Gillian, kind of related to that. So for our larger trial, we do a lot of qualitative work, and that's obviously a lot of data that tells us about those different versions of the intervention that people are receiving. And I think somehow, kind of, if there are two top contenders, building that in somehow would probably be quite useful, because there is a lot of data there, albeit qualitatively. I think it would be helpful to kind of say up front before you do it how you would do that, rather than just kind of using it afterwards. I think it would take some thought of how exactly to use that, but I think it could be a good source of information personally.
Okay, thank you.
Great. How about, you mentioned the leaflet will be now used in a larger optimization trial. Is there space to test the two versions, or will it be an on-off component?
So in the larger trial, it will be an on-off component. I think if we were to test the two versions, there would probably be such a small difference between them, that it would just kind of not be useful. Like, it wouldn't have any impact, because the difference between those two versions is so small already. We probably wouldn't see anything too interesting. So we did just choose one and take that forward.
Great. I love that you've given us a reminder here, Sophie, that sometimes what we eventually consider components can also be optimized, which is a neat thing to keep in mind. There's also a question here on a technical note about Bayes risks and using Bayes factor. I'll say that I have to think a little bit more about the use of Bayes factor in this context, but one thought along these lines is that it might be worth a reminder that in the optimization randomized control trial, we are really operating with a decision priority perspective here of trying not necessarily to conclude definitively that one leaflet is performing the best, or that one leaflet definitively outperforms the next leaflet, but rather trying to make the best use of the available information to choose a next step. And I think that in this case, the general strategy of going with the version that best accomplishes the initial optimization objective and then moving forward to subsequent testing fits that perspective and that priority. But I will certainly think more about what Bayes factor could contribute. One thing we have thought about, and Sophie and I have talked about this as well, is whether we might benefit from more explicit quantification of the uncertainty around these two estimates, or additional estimates. So for instance, in a full factorial trial like this, we also have an estimate for the lower level of everything. We might make a probabilistic comparison, for instance, between the version that we're considering as the optimized intervention and that version with everything set to low. But again, in this case here, we decided not to go there because the real goal was to take on that decision priority perspective and choose the one that seemed to best fit the optimization objective. Any other questions? In the meantime, I'll ask a question. Sophie, one of the things that we have thought about in thinking about a comparison between the two approaches you've mentioned, the Dave approach and the component screening approach, is that even though a Bayesian paradigm might feel intimidating, the Dave approach might actually be easier to apply than a systematic screening approach. Do you have any thoughts about the relative ease of the two processes, having just applied the both of them?
Yeah, I mean, absolutely. If so I'm not a statistician by any means. So the Bayesian approach did scare me off slightly to start off with. But I think once we've done it, it's quite clear how much easier that was to apply. So that CSA approach, hopefully you probably saw me trying to explain the interactions. They're quite difficult to interpret, as I mentioned, whereas Dave just didn't kind of involve any of that, so that was really helpful. But I mean, yeah, Bayesian statistics, they don't come naturally to me, and I'm very much still learning, so need support on that. But yeah, overall, the kind of overall ability to apply it, definitely a lot easier, I would say.
Yeah, one of the things I really appreciate about your presentation is the reminder as well that in both approaches we benefit from the sort of interpretation you demonstrated of the main effect and key interaction effects. And I think you've given a great illustration of why it can be really useful to interpret those, like to find the factor with the strongest main effect and learn from that and certain key interactions, where the real difference then is whether you have to rely on those to choose the optimized intervention or whether there's some additional information from the expected values themselves.
Yeah, I think we obviously learned a lot from kind of looking at that and going through all those interactions. And so I think I would always look at them and go through them. But yeah, it was when kind of making the decisions, that's where the difficulty seemed to come, like, do I screen this in, do I screen this out? So yeah, I agree.
Great. Well, thank you again so much for your presentation, and thanks everyone for your time and attention today.
Thank you.